Thank you, Jim. Our next speaker is Norbert Heinrich from University of Munich.
So thanks very much for inviting us to this wonderful meeting, and especially after June's presentation, so it stays a bit within the family. I have two hats on here. One is, of course, as June already alluded to, the Panacea Consortium, which is refunded and starting up as we speak, and the German Center for Infection Research, which is so charmingly abbreviated as DEZIF in this slide. I would like to give you a brief update on the benzothiazidone 043 development and briefly speak about our plans for phase 1 and phase 2A studies. So to start with the background, BDZ-043 is one of the group of DPR-E1 inhibitors, which is active on the cell wall of the mycobacteria. It's a small molecule with an active moiety that covalently binds the enzyme, so it's a suicide inhibitor, a bit unusual in that respect probably, but that probably has its advantages. The compound has a relatively long history. Patent was filed in 2006 for the first time. It was developed by Alere for some time, and then Alere decided to stop development. And then finally, 2 years ago, there was a cooperation agreement signed between the IP holding institution in Germany and LMU, our institution, on continuing the development of BDZ-043. And we were very fortunate to receive funding from the German Center for Infection Research and now also from the EDCTP on continuing development. We're currently planning to go for a scientific advice at the German EMA regulatory agency. Preclinical toxicity needed before phase 1 is complete, as we think, and as I said, funding seems to be available for continued development. Yeah, we are planning after this scientific advice to start the single ascending dose study later this year. Just a little excursion on efficacy studies. Some of you may already have seen this. We have done a study within DEZIF using BALB/c mouse model where mice were treated for 4, 6, or 8 weeks with different dosages of BDZ-043, and the comparator was isoniazid monotherapy. And just to compare the, well, historical is probably not the right word, but the previous data from Madi Makar, of the discoverer of BDZ-043, you could see that in the lungs there was basically about 1 log reduction over 4 weeks treatment with the compound compared to other compounds in this publication. And we have done, as I said, several doses, and as you can see here, after 4 weeks of treatment, we are seeing something a little short of 1 log reduction, so we are in the same area. But what you can also see is that higher doses than 50 milligrams per kilogram increase the efficacy, so increased killing of lung CFUs. And if you continue through treatment here over 6 and over 8 weeks, the dose dependency of this killing became even more evident. If you look at this in a more familiar format with well, continuous lines, you can see that the higher doses, starting with 250 milligrams, 500 and 1000, somehow didn't show much difference anymore, so we think that this killing is the maximum efficacy that we can get with this compound under these conditions. So on the safety findings to date, we don't see critical toxicity in the preclinical toxicology assessments. There doesn't seem to be a potential for enzyme interaction. There's no hERG effect, and we have a relatively high NOAL in rats at 170 milligrams per kg. The next higher dose in this study was 420, where there was slight toxicity observed. And in mini pigs, the second toxicity species, the NOAL, was 360, which was actually the highest dose given. So all in all, that's quite promising. Now the plan for phase 1A, and I think we've learned a bit from the experience working with colleagues from Curiant in their phase 1 study, and similarities in that respect are that BTZ is a compound that is not very well water soluble, but rather highly protein bound and lipophilic, so we anticipate there might be a significant food effect. So we're planning to start dosing with 200 and 400 milligrams in an escalating dose study. We are planning then to call back the 200 and the 400 milligram cohort to dose them again in a fed state, and then we would do an interim analysis to see the magnitude of the food effect, and then decide to continue in the higher dose stages with the condition that gave us the better exposure in the lower doses. And we're planning to go up to 3,200 milligrams if tolerability allows. And then to shorten time, because this, I guess we all share the frustration that all these developments take quite long, we hope that we will be able to put this phase 1A and phase 1B into one protocol, and after an interim analysis, select two well-tolerated, highest well-tolerated doses from phase 1A to go into the multiple dose phase 1B part of this study. And then from phase 2 onward, the drug is going to be slotted into the Panacea development pathway. This is the Panacea Gantt chart. I'm sorry, this is a bit busy, but you can probably see that there is a track for high-dose rifampicin. It wouldn't be Panacea if there were no high-dose rifampicin. There's a track for Q203. And there's a track for BTZ-043. We are planning one large phase 2BC step study following the design that Patrick and Michael have published, but it's possible that BTZ may not be on time to enter into this study right from the start. So we are working on it to get it ready for phase 2A as soon as we can, but we may have to slot it in later. And coming back to a comment that was given today on sharing a common control arm and continuing enrollment while adding additional arms. So we've spent some thought on the study design, also based on past experience, and I just want to briefly allude to what we thought we would do with BTZ. This is a bit like a classical EBA study design where you randomize your patients to receive either control, HRZE, or the IMP at monotherapy in several different doses. Now to generate a data set before phase 2B that is as rich as possible, and that would prevent us as much as possible from making uninformed choices on dosing or on composition. We would add to this study design a second randomization. And of course, since you cannot do monotherapy in patients of more than 14 days, we would then randomize the patients after their 14 days of monotherapy to go on the IMP with different backbones. Okay, so one possible backbone would then be HRZ, and another possible backbone might be what the scientific community sees as favorable at this point. And from our point of view, the most promising thing seems to be bedaquiline pyrazinamide at this point. Of course, we're happy to receive your input on this. The advantage of this design is not only that you'll be able to observe your drug on safety for a longer time, you'll be able to observe safety in combination within this one study, but also we will have a little more time to look at pharmacokinetics. So the usual way would be to look at, of course, first dose PK, and then look at steady state PK at day 14, which would give information on drug accumulation if there were any. BTZ has a short half-life, so we don't expect much accumulation. or on potential enzyme induction by day 14. And then when we dose the drug together with two different backbones, we might be able to look at potential interactions with companion drugs when doing the PK at day 28. And another potential measurement to be done in such a study would be metabolic phenotyping by using a probe drug cocktail. So we've come across this concept talking with Uwe Fuhr in Cologne, and of course Rob Arnolds was very instrumental in getting this forward. So basically what you would expect to do there is to give probe drugs in subtherapeutic concentrations that are metabolized by a well-known pathway and ideally be metabolized by just one CYP enzyme. One prototype is midazolam, which seems to be exclusively metabolized by CYP3A4. So we would give the probe drug cocktail to the patients pre-dose and do an intensive PK curve of those, give that at day 14 so we would know whether our IMP has enzyme induction capabilities and would accelerate clearance of the probe drugs, and we would do it again at day 28. Now, this is the current idea. It may, of course, still change until we can implement it, but at least, yeah, that's what we were thinking. Yeah, allow me to conclude by saying that we are an open consortium, and we are, of course, always open to people to approach us with ideas and combinations, and so we have a track record of acquiring public funding, and we'd be very happy to talk. And yeah, let me acknowledge, of course, the CPTR for inviting us to this wonderful meeting, and our team in Munich, Michael Hölscher, Julia Dreisbach, Elmar Saathoff, and Sarah Constant, team at DECIF, and our funders. Thanks very much.